Hello, everyone. Welcome to the first episode of Retina Chats. I'm Mohammed Ghanem, and with me, Dr. Mustafa Manhali.
Hello.
Hello, everyone. Today, we'll be chatting about a case of simple tractional retinal detachment. So, first of all, let me ask you: do you believe that we can call any vitrectomy surgery as a simple vitrectomy or a simple tractional retinal detachment?
Actually, vitrectomy, as a definition of a surgery, is a very complicated surgery with a lot of complication, even intraoperative surgery. And you cannot call any vitrectomy as a simple one because even in diabetics, not all diabetic vitrectomy are the same, and even in the same patient, not both eyes are the same, even with the same degree of PDR or traction. So definitely, there is no what is called a simple traction retinal
I
detachment.
believe we all have our bad experiences that we
Sure.
just
Yeah.
can't call anything simple. So let's start. So this is the my case. It's a 50-year-old male patient with diabetes for almost over 20 years, presenting to me with a tractional retinal detachment and diminution of vision for some time. First of all, in the preoperative period or when you're counseling the patient, do you ask him about the diabetic control? Are you concerned with this? And would you postpone surgery for more vigorous diabetic control?
Yes, I believe that diabetic control or glycemic level to be controlled pre-operative is very essential to avoid even post-operative complication as vitreous hemorrhage. But this depends on how this patient is doing in his life and the condition of the other eye. Is it a seeing eye that the patient can manage and go on, or it is also a blind or complicated surgery, complicated retinal detachment? So I believe that controlling glycemic level, yes, without compromising the retina condition more and more, as in this case it looks to be a little bit cold. This is not an acute case with this detachment. So if the patient is is completely uncontrolled with a glycemic level like 14 or 13, I believe that controlling this would avoid a lot of post-operative complications.
I usually don't postpone patients for glycemic control. I'm just more concerned that they would lose vision in this eye if I postpone the surgery more and more. Let's talk about the surgery itself. You noticed here that I went directly into the vitrectomy and going into the attacking the posterior hyaloid directly. We can just rewind a little bit here, and I didn't go with the classic teaching of core vitrectomy and then shaving and then posterior hyaloid detachment. I just went into the posterior hyaloid directly. Do you believe that this is advantageous, and do you do this technique often?
Actually, I believe that, and I prefer to do like a peripheral vitrectomy and to do like a circumcision of the vitreous to separate the peripheral vitreous from the central part. And this offers you a very good advantage of relaxing the central part and relaxing the traction from the periphery. And this even allows you to go in the right dissection plane, so you can go under the membrane as you are going to show us, and you can even remove this membrane if you have separated from the peripheral traction, because if it is tracted and you are going to attack the central part, this traction or pulling may don't allow you to go beneath this membrane, and even it may cause iatrogenic breaks.
Yeah, exactly. And just to make your point more clear, that if we do an iatrogenic tear early on in the surgery without removing the posterior
Yes.
hyaloid, this makes things more complicated, and we can even not complete the surgery as usual. Okay, so now I've done the almost a good part of the vitrectomy, and I'm here attacking the membranes. Um, in these cases, would you consider bimanual surgery, or do you just depend on unimanual surgery?
In this case, especially, I would go for, as you have doing, I would go for unimanual surgery because this is an easy membrane that you can dissect with the cutter as you are showing us. And even the central part was separated from the retina. So you don't need to cut an epicenter from the perimacular or perifoveal area. And with just doing this aspiration, and then you raise the membrane, then you go under the membrane. This is a very good step that you are doing well, and this shows how the membranes will be removed. I would do this step different from
More
you.
cautiously, yeah.
Yes, because you have pulled a little bit tougher than usual, and I don't know if it's going to complicate or not.
We'll see. There's an eogenic tear that we'll see later on. So yeah, I wouldn't go for bimanual surgery as you said, and here I'm just pulling on the membrane with the forceps, and there's just one part that had a more tougher traction than needed, and it caused an iatrogenic tear. Here I'm using the cutter with a high cutting rate and low vacuum to just debulk the membrane, and I'm even using the fold back technique. This helps to decrease the incidence of iatrogenic tears with the cutter.
Let me add to what you have said, that the introduction of the 25 gauge cutters with a high cutting rate like 20 Ks is a very good tool nowadays, that you can even avoid any nitrogen breaks, go beneath tough membranes, and even doing a very good segmentation. So I prefer to use the 25 gauge in all diabetic patients right now.
Yeah, sure. With advancement of technology, we find that steps that need a lot of skill are much
Easier.
easier. Yeah,
Yes.
and we're needing less and less skills over time. So this is a step that I know that you're not doing regularly, and it's a bit controversial. You don't inject triamcinolone, right?
No.
I believe that it's a very important step, especially in diabetics. I inject almost 100% of my vitrectomy cases with triamcinolone at the end of surgery, just to make sure that there is nothing left, there's no hidden membranes. And in this case, it wasn't that beneficial. I didn't find anything, but we'll show you in the next episodes that uh, for me it's beneficial, and we'll find membranes that are not usual that I cannot see without the triamcinolone. Now I discovered the iatrogenic tear, and doing a fluid to fluid exchange, just removing all the thick subretinal fluid using the cutter. So the important question that we all think about in every vitrectomy case: what will be your tamponade in this case with this small equatorial or somehow inferior retinal break?
I think it's almost an attached retina. You are going to leave it when, after fluid air exchange, the retina will be flat, and you are going to laser it. And as you have said, this is a very small, tiny tear, so I would not choose any tamponade except air.
Yes,
So
exactly. I left
air
this
is
patient
sufficient.
on
Yes.
air, and this is very sufficient. Here I'm doing peripheral indentation vitrectomy for, especially for the 6 o'clock condensed vitreous hemorrhage. Do you usually do this step, and do you find it helpful?
Yes, and I urge everyone that is doing vitrectomy to conclude the surgery with doing peripheral shaving and screening, to screen for any, whether iatrogenic or even a tear present in these cases, because it's one of the most common causes of recurrent detachment in diabetics, or even incipient lignotogenous retinal detachment. So I like the way you are doing. I think the assistant,
Yeah, assistant is
yes,
helping you.
is indenting to you, and this is you are going from one quadrant to another, and this is important to exclude any area of tears or peripheral degeneration that need to be
Yeah.
treated to
Other than
avoid
tears, I
detachments.
find that removing this vitreous
Yes.
hemorrhage, I find that it decreases the incidence of post vitrectomy hemorrhage and recurrent vitreous hemorrhage in the late post-operative period. So yeah, now I'm lasering, doing the PRP and lasering the retina. Would you prefer doing the PRP after a fluid air exchange and on air?
Yes, but this depends on the lens status. So if as in this case, it's a phakic patient, so I prefer to do it, yes, on air, because it offers a wider field of vision, so I can reach the periphery on one step. So in phakic patients, I believe it's, yes, it's better. But in pseudophakic patients, when you shift from from fluid to air, there are some tiny bubbles at the back of the IOL that may hinder your field of view. So I don't like to sacrifice the nice view that I can do the laser, especially when we have an iatrogenic break, to sacrifice this good viewing field after shifting to air. So in synthetic patient, I usually tend to do it over fluid first.
Okay, perfect. Let me. The final question: would you tell your patient and this patient to position in any way? Do you find it beneficial in this case?
I don't think so. There is no need for
Yeah,
positioning.
exactly. I usually don't tell them to the position in one way or another, and since it's a small tear, I wouldn't bother.
Did you inject this patient as at the conclusion of the
I
surgery?
injected this patient before surgery. I usually inject patients that I'm just concerned about the intraoperative bleeding or the post-operative bleeding. So I injected this patient because I felt that the new vessels are juicy and they could cause some problems in the intraoperative period.
And don't you have the gut that or the feeling that when you inject patients, that the membrane become a little bit more sticky and a little bit tougher than other that didn't receive preoperative
I find
injection?
them easier to peel. They become more brittle, if that's what you mean. But my main concern is the bleeding. This is a more advantage, or an extra advantage that happens with injection. Okay, so thank you very much for listening to us. This is the conclusion of our first episode. Stay tuned for the next ones.
Thank
Thank
you.
you.